I would like to invite Subina ma'am for her talk on retinopathy of prematurity and the role of imaging and the Retcam.
So how many of you in your institutes are seeing retinopathy of prematurity? Just two? These are the only institutes. I think nursery must be there in all the institutes. So you all know that retinopathy of prematurity exists, right? So let's see if I make you wiser or not. One question. What is the screening criteria for retinopathy of prematurity? Birth weight, please answer. You can be louder. Less than 1.5 kgs. Anybody differs? Anybody differs? She says less than 1.5 kgs. बोलो यार ठीक ही बोल रहे होगे. All right. The blanket statement is 2 किलो से कम बच्चे को स्क्रीन कर लो यार. ठीक है? Yes. 1.5 used to be there, but now with new guidelines by Neonatology Forum of India, the things have slightly changed. And what is the period of gestation? All right. It goes till 35 weeks, also 35 to 36 weeks, in case risk factors for ROP are there. So what are the risk factors for ROP? All right, what else? Okay, let's see if we become slightly wiser after this. So I'll be talking about ROP screening, role of fundus, photography, and Retcam. It's basically going to be about ROP screening. If you people learn to do ROP screening, I think fundus photography is basically for documentation. Why we people emphasize and why we are so much emotional about the subject, because India has highest number of preterm babies. We all need to learn how to screen for ROP. We all need to learn when to send the baby for screening, right? And it's a potentially blinding disease of preterm babies. And if you look at the numbers, then the preterms at risk of developing ROP are around 2 lakh per year. And each baby needs to be screened, and with repeated screening visits. And about 10% of them are going to require the treatment for ROP. And these repeated visits, if they are done by the trained people in ROP screening, we are just 150 odd people who are trained in doing ROP all over the country. So we need everybody joining hands. We need it to be done by a comprehensive ophthalmologist. And you have to follow up these babies till the time the retina vessels mature, or the baby develops ROP, or baby reaches 45 to 50 weeks of postmenstrual age. I think it's written wrong here. So we do it till 45 weeks in our setup. The latest guidelines for preterm screening are period of gestation less than 34 weeks, birth weight less than 1750 grams. But in case your period of gestation is either not known and the baby is having risk factors for development of ROP, then the screening guidelines are extended till 34 to 36 weeks of gestational age, and till 2 kgs you have to screen these babies. So most important risk factors: prematurity and birth weight. For each 100 grams increase in birth weight, there's decrease in ROP risk by 27%. So that emphasizes the importance of birth weight. So when we ask birth weight kitna tha, it has to be documented properly in your file chart. The risk factors for ROP, you did name a few, so it's just all multiple births, outborn babies, whites, oxygen supplementation, light vitamin A deficiency, apnea. They're all a whole lot of risk factors. And when we did a study in our setup, we see double volume exchange transfusion as the most important risk factors for development of ROP. When to screen? So when do we do screening for ROP? The first screening has to be performed at 4 weeks of postnatal age. So this is a famous slogan given by Dr. Subhadra, 30 din roshni ke. Right? That is that in neonates who are less than 30, who are premature or less than 32, 34 weeks, you go ahead with screening in first 4 weeks. In case your baby is less than 28 weeks of gestation or birth weight is less than 1200 gram, then you in fact prepone your screening by 2 to 3 weeks. You have to go earlier. Before discharge from hospital, you must screen these babies and you must talk to the mother and emphasize on the importance of screening so that you don't miss on these babies. The median age of detection of stage 1 ROP would be 34 weeks of gestation. If it progresses in severity, ROP needing treatment appears at 34 to 38 weeks. So you must know, once you are looking at the baby, the first question which is asked is post-conceptual age. So 34 to 38 weeks, you are seeing dilated tortuous vessels in the posterior pole that raises antennas. Well, it could be ROP there. Screening is done under pupillary dilatation, and what we do is phenylephrine 2.5%, cyclopentola 8.5%, or what you could do is Tropac P, simply the medicine you get diluted into half, 2 drops instilled twice, that means 1 drop at each time at 20 minutes interval. Don't forget to wipe the excess, because in case it's absorbed systemically, it leads to cardiac problems. And I mean, we've had a death because at that time we would just tell our attendant to put drops in the eye, and he, to impress us, would continue to put the drops. And then the deaths can also occur, so it's a very serious medical legal issue. Prefer putting the drops yourself, or prefer your once you're putting with a cotton thing should always be in your hand so that you can wipe the excess. For screening, you need very simple thing, wire vectis, eye speculum, and mind it, wire vectis is for globe rotation, not for indentation. To begin with, once you're not seeing ROP, you try to indent the globe. Once you try to indent the globe, the baby lands up into bradycardia. So don't ever do that. The wire vectis you have will be for globe rotation. And mind it, you don't even need wire speculum, you don't even need wire vectis, because you just need patience. Just carefully look, specifically to begin with, you can start with the temporal retina, because that is the place where you are going to see the ROP developing first of all. Just have patience, the baby will move the eye temporally, or maybe you can give a slight rotation to the head. You will see that the baby does move the eye temporally, and you will be able to get glimpse of the retina, and you will be able to make your diagnosis. Only for very serious cases, or when the baby is not rotating, you need all this eye speculum and wire vectis. But in case you are doing this with eye speculum or wire vectis, then you need to do it in nursery. Otherwise, you could have problems and you will need to rush the baby to nursery urgently. In case you are doing in your operation OPD, then avoid using eye speculum and wire vectis. Now, there are various algorithms which have come up where neonatologists could help you or call you. Well, the baby is into the alarm group. I mean, we did do a study for WinDrop. WinDrop is algorithm where you put period of gestation, where you put the birth weight of the baby, and it rings alarm according to the gain of the birth weight. It has been seen if at 6 weeks the baby's weight does not double, it normally rings the alarm, and the baby would need treatment. So you could have these kind of algorithms. We did in this study, WinDrop alarm was giving us good, I mean, it was had sensitivity and specificity of 80%, only in cases where you had neonatal congenital malformations. That was the issue when you were not able to get the alarm in these babies. And in case you have the facility of teleophthalmology, you have Retcam, then you do take up a set of 5 images. You do the central image, the peripheral, nasal, temporal, superior and inferior, and these set of 5 images can be used for diagnosing retinopathy of prematurity. One image will not do. So with your Retcam, it's a very simple thing. You put viscoelastic profusely, lightly you hold this Retcam, the handpiece with 130 degrees lens field of view, and then you do, with the movement of the hands, you can do nasal, temporal, upwards and downwards. Here you don't tell the baby to move the eye, he'll not move the eye. And it has been seen that tele-ophthalmology decision regarding treatment and referral has around 95% sensitivity and 93% specificity. NICU nurses were also found to give us the diagnosis in 100% of the cases, the correct diagnosis. It was in Sundrop study. So Retcam images, they increase the parental compliance also. It has been seen, once you click a Retcam image, you show the parents, well, this is what it is. Your child has not developed, the vessels haven't developed in your child's eye properly, then the compliance increases. The another thing is, yes, once we document on Retcam, we can use it for teaching purposes and also for documentation, because this has medical legal issues. So supposing when you saw the baby, it was not treatable ROP. It was not reaching the time when you had to treat the ROP. You have already documented in your Retcam. So you can tell, well, at that time it was not treatable. It was treatable and baby is lost to follow-up. But you must mention clearly when the next follow-up is, so you mention it with a date. That will save you a lot of trouble. Documentation of ROP after screening has to be done in terms of stage of ROP and zone of ROP. Zone tells you the location of ROP. With the disc at the center, you draw radius with the draw circle with the radius of twice the distance between the disc and the macula. This is zone 1 ROP. Zone 2 would be the peripheral rim from the nasal ora serrata with the disc at the center. This rim is beyond zone 1 is zone 2, and the peripheral rim which is left behind the crescent is zone 3 ROP. Nowadays, they've also added a posterior zone 2 ROP, which is 2 disc diameter. Beyond zone 1 is posterior zone 2, and they've also added the concept of notch. It has been seen that sometimes your ROP, there's incursion of ROP in the posterior zones. So then you will be telling the worst stage of ROP, what you are seeing, that is how you document. And if you look at this, must be stuck in the ROP file, neonatology file of all the babies, where you also mention whether the baby was dilated at that time or not, because some babies who are very severe ROP, there would be engorgement of the vessels and your pupil may not dilate. So it must be mentioned when you saw the baby was dilated or not dilated, and what is the next follow-up visit, what is your stage and zone, what is your diagnosis. It must be mentioned. This is just to tell you how to diagnose zone 1 ROP. You have 28 diopter lens. Your disc is at the rim of 28 diopter field of view, and whatever field you are seeing is zone 1 ROP. So that's how you diagnose zone 1 ROP, and beyond it would be zone 2. And zone 3 you will not see very clearly. For that you have to do globe rotation. This is just to tell you what is stage 1 ROP. There is a line, demarcation line between the vascular retina and avascular. This is stage 1 ROP, because once you are screening, you must know what you are looking at. And if you do fluorescein angiography here, you see that the vessels, they become more tortuous here, and you start seeing the shunt vessels here, which do not leak. This is zone 1 with a notch. This is, again, you see, there's vascular and avascular retina junction. The notch becomes very clear with your fluorescein angiography, but it is not a must for every case. This is just to tell you this kind of notch may exist, which you could pick up clinically, you may not pick up clinically. But normally it occurs in the temporal arcade. Once this line gets a volume, it becomes stage 2, or ridge is there. This is stage 2 ROP. And if you do fluorescein angiography, you will have AV shunts, which would be visible here, but they are not leaking. Stage 3 would be when the ridge has neovascularization, which starts coming up, and then you will also have leakage on fluorescein angiography for the vessels. 4A is once the retina gets lifted up, but macula is not involved, it is stage 4A. Stage 4B would be when you would have the involvement of macula also. Stage 5 ROP is total retinal detachment. You start seeing the white reflex, and once you look inside, you will see that total retinal detachment. It could be open, it could be open, close, or it could, this is picked up on ultrasonography, whether it's closed posteriorly or open posteriorly. The best would be if it's closed anteriorly, open posteriorly, yes, you do, these patients do well after surgery. Then there is aggressive retinopathy of prematurity. In this newer classification, you have aggressive posterior ROP terms changed to aggressive retinopathy of prematurity. Here you have to be vigilant. Once you see dilated and tortuous vessels like this, see very carefully, and you pick up these flat neovascularization. If they're flat neovascularization, you have to look for them. Otherwise, this ROP is going to progress straight to stage 5. Straight away, it will not go through various stages. It would just, the retina would get lifted and it will be stage 5 ROP. So this is just a cartoon to tell you. This is picked up on from YouTube. So this is 4 months of gestation. The vessels start growing, and this is, they are going. They've just stopped at zone 1, and you start seeing this demarcation line, which is stage 1 ROP. And this later on could get a volume. It's become broader. A ridge forms. So this is stage 2 ROP. And if this is again not treated, then you have these vessels growing up. You have new vessels which grow over this ridge. They get lifted up. This is called stage 3 ROP. And ultimately, if you are not even taking, this is the time you have to treat. You have to treat, in fact, at the time before this. Then it would lead to lifting up of the retina. And once the retina gets lifted up, it is not involving the macula, it is stage 4A. If it involves the macula, it would be stage 4B. So we have to prevent this from occurring. We have to diagnose these babies earlier when we can treat them with laser treatment. And this is just to show you that with this Retcam instrument, what we can do is fluorescein angiography. There's a lot more information which you can pick up with angiography. This is the clinical picture which many of you may not see, the junction of vascular and avascular retina. Once you do fluorescein angiography, you get a whole lot of things which are very clearly, you see popcorns, you see AV shunts, you see foveal hypoplasia, you see capillary non-perfusion areas. So our fluorescein angiography, we are trying to get it into the classification of ROP, but as of now, it is not in the classification. It's just, yes, what we could see in our study, it was that with fluorescein angiography, there were many treatable ROP. Wherever you have vessels leaking, that becomes treatable. But this was beyond what we see clinically. FFA, just to show you, since it's on imaging, so it's a simple procedure done in the presence of pediatrician. You put the dye inside like you do for FFA. The dosage is 0.04 ml per kg of 20% dye. And this is, you see vessels filling up, and a lot more information on FFA. It tells you that most of the macula is not perfused in this case. So this could have bearing on the long-term visual outcome of these babies. Again, if you see clinically, you may not pick up these areas. Macula is hardly perfused here, and these big loops of vessels are there. Flat neovascularization is also better picked up on FFA. You could pick up some avascular islands, which you could pick up on FFA once you come to treat, because for treatment you have to do laser of all the avascular retina. So you have to be treating this avascular island also if you pick up on FFA. Plus disease is venous dilatation and arterial tortuosity, at least in 2 quadrants. Iris neovascularization, iris vessels are also engorged in this, so you may not have the dilatation of iris for these babies where you have plus disease. And vitreous haze could also be the indication that this patient has plus disease. You'll have carefully look at it. Earlier it was all 4 quadrants have to be dilated and tortuous to call it plus disease. Now even 2 quadrants of dilated and tortuous vessels will make it a plus disease. And when does your baby need treatment? It would be zone 1 ROP. You would treat only once it's stage 3, even without plus disease. With plus disease, you treat all the stages, stage 1, 2, or 3. In zone 2, whatever red is what you treat, and whatever yellow is what you will follow. In zone 2, stage 2 and stage 3 of ROP with plus disease you will treat. But if it is no plus disease, you will not treat these babies. So plus disease, diagnosis of plus disease becomes very important, which you can all do looking at the posterior pole with your indirect ophthalmoscope. How much is the dilatation and tortuosity? It is more than normal or not. And then the stages I have just shown you, you have to document the stages. I showed you a picture where you have to document each one. And then you have to see whether the baby needs treatment. You treat it, very good. You do not treat it, refer the baby. Within 2 to 3 days, the baby needs treatment. That will prevent many eyes from going blind. So this is Just putting up the same table here, I just told you what is the international classification of ROP for type 1 ROP. Type 1 ROP is treatment requiring ROP. Type 2 ROP is whatever you are seeing in yellow, which is where you have to closely follow up these babies. They may not require, they may regress also. So this is time when we all need to join hands. ROP screening is nothing. It needs dedication, precision, perseverance, and patience. Increasing burden of ROP emphasizes the role of comprehensive ophthalmologists, or in fact, all of us, in screening ROP and recognizing the treatment requiring ROP. Let's pledge, let not an eye go blind. It's already a prematurity week which is going on, so please pledge that we'll all screen, at least attempt in the beginning, then you'll see it's very simple. The babies don't even cry much. So you feel कि कैसे देखेंगे छोटा सा बच्चा, जब तुम देखना शुरू होगे, it's the easiest thing to do. So do that. Thank you.
Thank you so much, ma'am.